Hello, and thank you for tuning in to this ASGCT Community Quick Take on preparing for unknowns. I'm Crystal Delic-Grammaticus, and I'm the co-founder and director of research for the Milan Syndrome Foundation, which is a rare overgrowth and neurodevelopmental disorder. It's an honor to be here today to moderate a conversation that is both timely and deeply important for families and individuals navigating the possibilities of cell and gene therapy. When we talk about these therapies, hope and uncertainty often go hand in hand. So we are taking a closer look at what lies ahead for someone participating in an investigational clinical trial, or more importantly, what still might not be known. I'm pleased to introduce our speaker, Dr. Amy Waldman, a pediatric neurologist at the Children's Hospital of Philadelphia, and someone deeply committed to advancing safe, effective care for patients with rare conditions. Dr. Waldman brings both clinical expertise and a compassionate understanding of what families face when weighing treatment options that involve unknowns. So let's dive right in, Dr. Waldman. A goal of this discussion is to better understand the risks and unknowns for gene therapy, but we should first understand the trial design. Dr. Waldman, why aren't all drugs given open label as opposed to a double-blind design?
Well, thank you for having me. I'm delighted to talk about this today and hope that I can help our audience understand a little bit more about these trials. When we think about gene therapy, which for many people is such a hope to have a cure or a treatment for their disease, we think about getting the vector, getting the gene therapy. And a lot of people think that you should be able to get an open label design where you would get the gene therapy right away. That's not exactly the way it always works. There are often these double-blind placebo-controlled trials where some patients will get the gene therapy and some people will get a saline or a placebo control. And that is actually the best way to design a gene therapy, but it really depends upon the disease. If the disease is slowly progressive, for example, the progression is over several years, then a placebo-controlled design where some people get the disease up front and some people get it 6 months or a year and a half later, that could work very well. So in thinking about designing a trial, it's really about the disease progression that impacts the type of trial that is developed.
Okay, so just to make sure we cover everything, tell me more about antisense oligonucleotides or ASOs and how do they compare or differ to the other options that we've discussed?
That is a great question. So we've been talking a lot about gene therapy, which works directly on the DNA. The antisense drugs, antisense oligonucleotides, or ASOs, work on the RNA. So they work not on the DNA, but the next step in the pathway, which is the RNA. But because of that, they need to be given over and over again. So they're not a one-time therapy. Typically, they're given about every 3 months. Because you're getting a therapy every 3 months, these types of drugs, this class of drugs, does lend itself a little bit better to that double-blind idea, where some patients get the placebo and some patients get the therapy. Interestingly, antisense drugs are given through, most of the time, a spinal tap. So you're getting spinal taps every 3 months. And again, some of the clinical trial designs have involved a placebo, where some people get the drug and some people get saline. Some of the designs involve just a lumbar puncture or spinal tap and no drug administration, compared to a group that gets the spinal tap with the drug administration. So these are a little bit more challenging to design because people sometimes know if they're getting a spinal tap or not. But that's where a lot of our placebo-controlled trials come in, or through these antisense drugs.
Well, thank you for helping us better understand those designs. So we're going to move on a little bit now to kind of think ahead and to a new gene trial, therapy trial. And how many people usually participate in these trials?
I think it's important to remember that these are typically very small trials. It was a very interesting comment that a pharmaceutical representative once said in a family forum. They said, The goal is to expose the fewest number of patients to an experimental therapy. I think many of us think about these big trials for high blood pressure or other diseases where there are thousands of patients. And if there's a rare disease where there's 30 or 50 patients, I think many of us have the idea that all 30 patients that want to participate or all 50 patients that want to participate would be able to get into these trials. A lot of these trials start with under 10 patients in the phase 1 and might grow to 30 patients. But even in rare disease where the patients are limited, not everyone is going to be eligible. And the reason for that, again, is the drug is unproven, right? It's not known whether there's going to be safety or efficacy concerns. So the goal is to give the drug to the fewest number of patients to ensure that it's safe and efficacious before exposing a lot of individuals to a drug that may not be safe. The other interesting thing about many of these trials are there are administrations of the vector, the gene therapy, or the antisense, and they're staggered enrollments. So you give it to a patient, you have to wait to see how that patient does. You give it to the next patient, you have to wait to see how that patient does. So unlike other, maybe more traditional trials where the trial opens and anyone who wants to participate can get access to a drug, these are a little bit more staggered and happen over time to give us some time to make sure that they're safe and efficacious, or safety mostly, in between new patients getting exposure.
Okay, so I'm getting ready to ask you a pretty tough question now, Dr. Waldman. Is gene therapy a cure?
Many of us will say no, although I did use the word cure earlier. We would like gene therapy to be curative, right? We want to alter someone's genes to correct the protein or the enzyme or whatever the problem is that is causing the clinical symptoms. But we're very hesitant in the medical community to use the word cure. Most of these are treatments. We do hope that it mitigates symptoms and improves quality of life, but we're very hesitant to use the word cure because we don't know how long the effects will last. Is it curative, meaning that the gene is corrected and this will be lasting and lifelong? Is this something where the effects might wear off? An antisense therapy is not a cure. The antisense oligonucleotides, as we said, they have to be administered every 3 months, right? So that's a treatment, but not necessarily a cure. That doesn't mean that the patient wouldn't benefit and see an improvement in symptoms, we hope, but we prefer the word treatment to cure.
I see. So what are some of the more realistic expectations that a person participating in a gene therapy trial, could expect?
That's a great question. I think in medicine, we have the idea that you get a medication or a treatment and you see an effect, right? I have a headache, I take a medicine, my headache gets better. Of course, that's an oversimplification. The challenge, though, here with gene therapy is that the responses are not that quick. You don't get a gene therapy and then all of a sudden have an improvement in symptoms, right? So depending on the mechanism of where the faulty gene, how that impacts the body, there is time to see an effect. And we sometimes worry that the disease could be progressing while you're waiting for that gene to correct itself or the protein to improve or diminish or whatever the goal of the therapy is. So the reality is that we really expect stability. We don't always expect something to improve. So if you are looking for an improvement in your symptoms, something to get better, walking to get better, or speech to become clearer, that's sometimes a little bit challenging and may not be realistic. We do have a hope that the younger you treat someone with gene therapy, so for example, a baby with spinal muscular atrophy, right? If you can intervene quite early, then you may be able to change the trajectory. But if someone's not able to walk, it's not really realistic to say that with the gene therapy, they're going to be able to walk. If someone has some speech difficulties, it doesn't necessarily mean that they're going to improve in terms of their cognition or their speech. So I think we want to be cautious and we want to make sure that we're not overpromising on the benefits of gene therapy. And so really, I think of it as we don't want the disease to continue to worsen. So we don't want people to lose skills. We would like a plateau or stability in the clinical symptoms. Of course, the reality is we always want improvement. We do. But I think being realistic, especially if it's a brain problem, because the brain's not going to regenerate, stability is what we're looking for so that symptoms are not getting worse.
And it could take some time to see improvements. Yeah.
Correct. Yeah.
What are the biggest unknowns and potential risks, both now and in the future, for individuals participating in these trials?
Yep, that's a great question. So I think the most important thing for families to realize is that a gene therapy is delivered through a virus that is not, the virus does not cause any viral symptoms, right? You don't get a cold, for example, from the virus. But the virus still can activate the immune system. Okay, so you don't get sick from the virus, but it can trigger the immune response. So there are different periods of worry that I would explain to a family. So the first thing to worry about are the short-term toxicities. And that is you get the gene therapy and within the first week, your part of your immune system, something's called your complement, they can activate and they can attack the delivery mechanism around the gene therapy. So in the first week following gene therapy, we're a little bit anxious to make sure that there's no side effects and looking for things like vomiting or feeling ill or just not feeling right. Then that worry settles down a little bit. And in the first 1 to 2 months, we worry about liver toxicity. So this virus can go through the liver, and the liver then, as the liver's trying to process, the liver could experience some challenges and even liver failure. So in the first 1 to 2 months, 4 to 8 weeks after the gene therapy is when we worry about this. Now, to mitigate a lot of this, we do give steroids and other immune suppressions. So that's another risk to the patient. Now you're somewhat immune suppressed to an extent while we're trying to dampen the immune system so it doesn't attack the vector of the gene therapy. Antisense oligonucleotides don't have these same risks, but this is mostly for the gene therapies. So there are these short-term risks that can happen in the first 3 months. We have been surprised. We've seen some things at 6 months or longer, but it's really the first 3 months that are the most risky. And so those are the short-term risks. And that's just activation of the immune system. And then long-term, many of the gene therapies that are on the market today do not cause an expansion of a cell line or for like a cancer, like a long-term cancer, right? You're messing with someone's genes. If you try to activate and the gene can replicate, like you can have a challenge there. Most of the gene therapies that are on the market today don't do that, these AAV gene therapies. But in the future, we don't know what the long-term impact is going to be on that gene. And is it going to last? And is it going to remain as efficacious? Is the efficacy going to wear off? And because of the immune response, right now in 2025, you can't re-administer the gene therapy. You can say, oh, well, the effects wear off. I'm going to give it again because now you'll have an immune response to the gene therapy. So there are some long-term risks that can happen 10, 15 years down the line. And so we really need to follow patients very closely during that time.
So you're really, once you've had gene therapy, you continue to be monitored over a lifetime. That's what I'm hearing you say. Yeah.
Exactly. Now, of course, the frequency of visits decreases quite a bit, right? You go from seeing us very like weekly or every other week, to once a year. But we just need to make sure that families, especially if they're transitioning out of pediatrics into an adult world, that they still are seeing someone experienced in gene therapy. And there are lots of adult providers now that are also experienced in gene therapy. It becomes part of your routine, your primary doctor, but also your gene therapy doctor looking for changes over time. And then the primary disease expert, so your neurologist, for example, in our world, or a metabolic physician, so you have a team, your primary doctor, your metabolic neurologist, your disease expert, and then we would really recommend a gene therapy expert, to follow over time, because your disease expert will tell you about progression of your disorder. And then a gene therapy expert, which could be one and the same, but not always, will tell you about the risks of long-term gene therapy and things that they want to look out for.
Are there any examples of challenges or medical issues arising much later after they've individuals have received a gene therapy?
What we worry most about is, for example, like a liver tumor,
I
right?
see.
So in the IV, if you're given IV gene therapy, it goes
Mm-hmm.
through your blood system, it goes through the liver, and there might be a problem in the liver long term that might happen years and years down the line. So that's what we most worry about. And that's why it's great to have, for example, a neurologist that has the neurology expertise, but then someone expert in gene therapy or someone that can look at the liver and evaluate the liver over time.
All really great information when you're considering all of these gene therapy options and keeping on top of the benefits, but also the real risks that go along with these pretty groundbreaking
Yeah. Yeah.
therapies. Um, so I just want to thank you, Dr. Waldman. Are there is there anything else that you'd like to add? This was really informative as a parent and advocacy leader.
I think the one thing that I want to say to parents is you don't have to feel pressure to participate in a gene therapy trial, right? Research is very different than clinical care. It's experimental. We don't know if things are safe. We don't know if they're efficacious. So, what I would say to families is make the decision that's best for you and for your loved one. There are some parents that feel, and I understand that they want to do everything they possibly can. They want to leave no stone unturned, and research is a comfortable space for them. But research does come with risks. So if someone is a little bit more risk averse, right? So if we think about the stock market, and I'm not trying to simplify these really complex relationships and thoughts and things, but there are people that are very comfortable taking major risks in the stock market. And then there are some people that say, you know what, I don't want to be the first. Let somebody else go first. Somebody else take a risk. And maybe, we'll let somebody else go. And what I would say to disease communities is there's space for everyone. I think sometimes our communities get a little bit fractured by some of the people who get into the trial are the haves, and the people who don't get into the trial because they're excluded or there's not enough room or the trial's closed are the have-nots. And I think we need to look at the patients who are participating in clinical trials as these unsung heroes, taking these risks and going first and seeing if something's efficacious. Gene therapy is risky, and it doesn't always go according to plan. So it is for the parents who want to do it, that's fantastic. And if that's the right decision for your family, that's great. For the parents who don't want to, and I'm using the word parents, but loved ones, caregivers, for people who don't want to do it, that's completely okay, right? Not everybody needs to be in these clinical trials. I just ask that each group respects the other group, that the group that is not in the clinical trial respects the path that the other patients may be paving for other patients, because sometimes we've lost patients in trials, right? We don't go into it with that idea, but inevitably, sometimes things happen in clinical trials that we're not expecting. So I would just ask communities to support each other. The patients who aren't in are sometimes upset that they didn't get into a clinical trial, but they also don't realize some of the real challenges that occur with being in a clinical trial. So support each other. We're all trying to get to that same place of wondering, do we have a new treatment for a rare disease?
Well, you've surely given us a lot to think about, Dr. Wellman, in terms of advancing clinical trials and how we can all contribute in this space and do what's really right for our individual needs and for our loved ones. So thank you so much.
Thanks for having me.